So we will be looking at some pearls and pitfalls of PSMA. My disclosure is on the slide. All right, so just to start out with getting the pearls out of the way, basically, so PSMA is prostate-specific membrane antigen, but it basically targets a lot of like vascularity, neovascularity, and any lesion which has neovascularity can have PSMA positivity. So remember to check for, like, you can't remember all the normal variants, so you should basically remember to check for normal variants, and any PSMA positive finding should be weighted against the pretest probability and clinical consequences of M1 disease, which is, very severe, and prostate cancer can be negative on PSMA scans, and for the focal therapy practitioner, it can detect MR invisible lesions and can help with the post-ablation recurrence. So starting out with non-prostatic findings on a PSMA scan, what can you see? So this patient had recently diagnosed PCA, prostate cancer, 4+5. You can see a lot of positivity in the prostate. And then there's this lesion in the mesentery. So what is that? And you can see in CT there is something there. So in this patient, this was appendicitis, which was undiagnosed during the PSMA PET scan. So that will look very bright because of the inflammation. Again, in this patient, newly diagnosed prostate cancer, PSA of 4.1, large lesion in the prostate, and lymph nodes also positive. And then he had this solitary bone lesion in the left femur, which kind of doesn't look very concerning, but it is very avid on the PSMA PET. And before checking for priors, they got an MRI, basically, and it was called a bone herniation and synovial pit. But if they could have just checked the prior imaging from 2015, it was there also. So always remember to check for prior imaging. And yeah, this was just a synovial herniation pit. Fibrocystic changes, these can have microvascularity. So these are usually positive on FDG PET. And then there are just normal structures, the cervical ganglia that we see symmetric. Like if you see symmetric uptake, which is not very avid but mildly avid, like you can get cervical and sacral ganglia, which basically they can have some uptake. And in this case, and this is one of the most common findings that we see in the liver, basically it's a hemangioma. On MRI, it's T2 bright, it retains contrast. It also retains a lot of PSMA PET. So always check for normal variants. So usually if you get a PSMA PET and it's a solitary lesion, doesn't make sense, the patient has a MET, get an MRI to confirm. So that ends up happening a lot. Again, it can detect other malignancies, any malignancy which will have it doesn't have to be prostate cancer, like it has been tested for ovarian, for thyroid. This was the thymoma of the mediastinum, which will also have PSMA positivity. Again, so if you're reading the normal prostate, like we have a pitfall in prostate MRI, like the central zone or the central zone around the ejaculatory ducts. It can have elevated diffusion signal and elevated ADC. So is with the also with the PSMA, the central gland can have a symmetric uptake bilaterally, and they can look like Mickey Mouse ears. Just pivoting a little bit, so MR invisible, PSMA positive, a couple of cases of that. And I'm pretty sure in this MRI, I'm not, or maybe AI will find a prostate cancer, but I'm pretty sure most of us won't. Maybe Dr. Turkby will, but in this case, this patient was PSA 9.8, 2 previous negative biopsies, negative MRs, persistently high PSA. In those cases, you are okay to get a PSMA PET, and this was the lesion which was detected. Very, very subtle on MRI, still maybe on T2, but nothing really on diffusion or ADC. And this turned out to be had Gleason 7 ISUP3 cancer. Again, it will detect, this is the MRI of this patient with very high PSA, Gleason 4+5. And on the PSMA PET that was discovered, there was a second lesion, which was also present. So it did not have unilateral disease, bilateral disease. And so prostate cancer detection by PSMA samples and pitfalls, you can have specific scenarios, persistent clinical suspicion, indeterminate lesions, active surveillance with negative MR. So PSMA PET has been shown to increase the negative predictive value and increase the sensitivity for MR, in addition to MR for in the detection setting. So post-therapy, just to rule out a little bit, so MRI is good for post-therapy prostate imaging, but it's not very, it cannot replace biopsy. So you still, like, even if the MRI is negative, we all biopsy our patients, right? So, and this has actually been proven. So this was a ablation patient. This patient basically had really high disease and ended up getting focal therapy at, ended up getting whole gland therapy at an institution because he just wanted it. He did not want anything else. So on the post-treatment MRI, you see that there's just a little bit, there's some normal prostate tissue, but there's just a little bit post-enhancement, focal enhancement on the left side. But on the PSMA PET, the whole gland is basically avid. So this patient had multiple 4+4 recurrences in the prostate. And again, so this has been published. So MRI for focal therapy of HIFU, it can, even negative studies can have, clinically significant disease. So, and so again, there are some phenomena that we should, as radiologists, that I did not know about, but as especially after hormones and surgery. So you can get flare phenomena after surgery. So this patient, after enzalutamide, you can see that the size and the PSMA positivity of this lymph node increases. So, but as you can see that the PSA actually decreased. So you always have to put that in the clinical context. So that's the flare phenomenon. And so PSMA-negative disease. So what do we do with PSMA-negative disease? So this patient, where the PSA 25 at presentation, non-targeted biopsy was done, Gleason 7 in 8+13 cores, and we have a really FDG, really prominent MR visible lesion with seminal vesicle invasion, and but this was completely PSMA negative. Like there was no PSMA positivity for it. And even the lymph nodes that he had were great. They did not have any PSMA positivity. And this was another case, and this was done in the hospital. Patient basically had some prostatic problems, and then they got a CT, and he had a big prostate, and he also had a large left inguinal lymph node right there. And so before talking to anyone, they got a PSMA FDG PET. So they showed diffuse FDG avid prostate and that lymph node in the, it was also avid. And even before then urology was contacted and they got a biopsy and they got adenocarcinoma and also small cell carcinoma in both of them. And then they wanted us to biopsy the lymph node also, but we tell them to get a gallium dotatate study because small cell lesions. And you can see that many more lesions which are positive in the abdomen, in the chest, abdomen, and pelvis. So small cell cancer on biopsy, remember to get dotatate scan on that. So PSMA negativity can be dependent on the tumor volume, variability and intensity of PSMA expression, intratumoral heterogeneity, neuroendocrine differentiation. So PSMA-negative tumors can upregulate the amino acid transporters and maybe image with oxybin. And that was my last slide. And thank you, Dr. Surasi and Galiza, for sharing the cases with me.